Okay, hi, this is a continuation of chapter 23, which is the chapter on vascular disorders. We already spoke about the arterial disorders, essentially things that are affecting the arteries. This section starts about venous disease or diseases or disorders that are affecting the veins. And then the last part talks about hypertension or high blood pressure. Okay, so chronic venous insufficiency is the most common cause of chronic venous disease. Basically, veins are unable to return adequate blood to the heart. Some of the causes, one of them is deep vein thrombosis. So there's a blood clot that forms in a vein deep in the body. So it's exactly what it says. And then also varicose veins, and which are caused by ruptured valves. Okay, so I guess the chronic venous insufficiency is sort of a more general term. So some of the associated conditions are things that are going to contribute to venous insufficiency, genetic predisposition. I mean, we said all these things before. Being female, right? I mean, in general, you see varicose veins in females. You don't really see them in males, though you do sometimes, but they're definitely more prevalent in females. Pregnancy, if you're over 50, if you smoke, you don't exercise, or obese, these are all going to affect the veins as well. And also, just to kind of remind you that, or a couple things, and I think we kind of said some of these things before, but if you think about veins, the pressure inside the veins is much lower than in the arteries. The walls of the veins are much thinner. Because the pressure is lower and you're returning that blood, to the heart, there needs to be some mechanisms in place that allow that blood to flow back to the heart. So there are valves, right? So basically, skeletal muscles will push on the sides of the veins to help push that blood through, because there's not a lot of pressure there. And then once it kind of pushes past here, this valve will close normally, okay? So this is kind of what this is showing you here. So normal venous valve during dilation of the heart, like I said, it would then kind of, right, so the blood flow gets through here during dilation, and then when it contracts again, this will cause this valve to kind of close, and so that the blood can't flow back. Okay, so you can see that the blood doesn't leak back. Sorry, just to continue there, right? So normally, again, the blood and skeletal muscle will help this. We'll push that blood past the valve. The valve will essentially close, and then that blood cannot flow backwards. However, if there is a damaged valve that leaks, it allows that blood to flow backwards, and then you can kind of see that blood will pool in the veins, and obviously isn't going to go back to the heart where it should. Okay, so kind of this dysfunction will contribute to a bunch of the problems that we're talking about, essentially. Okay, so again, low pressure in the venous system, I just said this, right? Skeletal muscles will squeeze those surrounding veins. That's sort of normal to kind of push the blood, but obviously you'll get extra, I guess, kind of sort of squeezing the skeletal muscles if you have an issue. And those veins can stretch, like I showed you here, right? Because blood will pool, okay? So obviously that's going to then sort of weaken the walls of the veins, right? Eventually, or you can also have rupture of valves, and then also clots form because you have this pooling of the blood. Some of the clinical manifestations: leg cramps, pain, right? Edema of the leg or ankle, thickening or discoloration of the skin on the calves. You probably maybe have seen this in people before. Heaviness and weakness of the legs, obviously because of gravity, that's where the blood is going to tend to pool in the legs. And so that's where you'll have either build up a fluid, you may have blood clots, a lot of times will form in the legs. Okay, so common complications: leg ulcers, so sores on the skin that will persist more than 6 weeks, varicose veins, and again, this deep vein thrombosis, which is just it's clots that are in veins deep in the tissue. In terms of diagnosis, obviously assessment of symptoms and triggers. You can use ultrasound to image something called venography, which is an x-ray with contrast that will be able to look for blood clots, right? And so again, it kind of depends on where that blood clot is and how serious the symptoms or effects would be. Also, there is a type of test called a D-dimer test, where basically it's a blood test where you can look for levels of fibrin. So basically, when that fibrin degrades, there's these products that are secreted in the blood, and if you see high levels of these fibrin products, it suggests that there is high levels of clots formed. And again, if the clot forms, in the wrong place or something like that, you can end up having issues. And so that's a way of sort of assessing how bad the clots are. Okay, so again, we said deep vein thrombosis, so the blood clots forming in veins that are deep within the tissue. So this is kind of showing you this is both, right? They're not deep, meaning not towards the surface. And so you can see that these clots start to form. And again, what can happen is maybe the clot that's here is okay, but when a part of it breaks off, it can then get lodged in a smaller artery or something like that eventually, or in the heart, right? And you can end up with a problem in the heart or the lungs. Okay, in terms of treatment, preventative measures. So, right, if you don't exercise, you don't move around, well, you better start moving around. If you're obese, right, deal with that. Also, there is something called sclerotherapy, where you can basically inject a solution like saline into the vein, and it will cause that vein to close. Lasers can be used, anticoagulants, right, blood thinners, and then you can even place a filter in the inferior vena cava to actually trap emboli, because again, you don't want those blood clots to get into the heart, because that could be fatal. So if you have this ongoing problem where you're producing these clots, it basically would prevent them from getting where you don't want them to go to cause a serious. Okay, so this next part is going to talk about hypertension. Okay, so high blood pressure, what consists hypertension, right? Consists in elevation of blood pressure above 140 systolic or above 90 diastolic. Okay, and I'm assuming in your clinical assessment class you're learning how to take blood pressures, and you can take blood pressures. We know that systolic number is that top number, and the bottom number is the diastolic. One is the pressure inside the artery when the heart is in systole, right, contracting, and one when it's in its when it's relaxed. Okay, and so again, this is saying in the brachial artery, right? That's the sort of common place to take blood pressure. It says local hypertension occurs in specific organs, right? So you can, you kind of say you have high blood pressure, but you can have this local kind of specific blood pressure. So if you talk about pulmonary hypertension, right, increased blood pressure in the lungs, it's due to left-sided heart failure. We've kind of already talked about this before, right? And then it also leads to pulmonary edema as well. So again, hypertension, I don't know that this is really causes, I probably needed to change this, but sometimes these are kind of listed wrong, but I mean, it's kind of effects, not really causes. Hypertension creates excess pressure on the arterial walls, as you might imagine. If you have arterial sclerosis, like we talked about a few chapters ago, that can thicken that arterial wall, and then lead to even higher blood pressure, right? Because you already have a smaller space there as well. If we look at the categories of high blood pressure here, or of blood pressure, you can kind of see normal, right? 120 over 80. Pre-hypertension, 121 to 139 over 81, 89, and so on. So stage 1 hypertension and stage 2 hypertension. You should be familiar with this. You should know around what normal blood pressure is and what it is if you're in stage 1 hypertension or stage 2. Okay, so for primary hypertension, basically no known cause. Okay, so about 90% of cases, basically you have high blood pressure. There are many factors like genetics, age, race, diet, right, smoking, alcohol, sedentary lifestyle that are all going to contribute to this. But again, genetics is a big one, right? But definitely sedentary lifestyle, smoking, and your diet is going to contribute to it a lot. We talk about secondary hypertension. There is some sort of identifiable cause, like hyperthyroidism, for instance, chronic kidney disease, or tumors of the adrenal gland. So there isn't a specific cause that's causing the high blood pressure. Therefore, you would then treat that cause. Some factors that will affect high blood pressure: hormones. We mentioned this renin, angiotensin, aldosterone system before. I don't know that you're responsible for knowing every single detail, but I'm going to show you a picture and talk a little bit about it. So you don't need to memorize the details. But basically, this is in response to a decrease in blood pressure, right? This kicks in, the system becomes activated to increase blood volume. Once that blood volume is increased, then blood pressure increases, right? If you talk about the sympathetic nervous system, right, fight or flight, it's going to increase blood pressure, okay? So, like I said, this is sort of the picture of showing you some of these hormonal and nervous factors that will influence blood pressure. Wherever you see a positive, right? That means vasoconstriction. And if you constrict the artery, that's going to increase blood vessels, right? And so you can see here, these baroreceptors are receptors that exist within the blood vessels to detect a change in blood pressure, right? How does the body know that the blood pressure is too low? It's these baroreceptors that will detect a change and then send that information into the brainstem, right? And then there will be some response that's emitted, so norepinephrine might be released, that will then go to the blood vessel, to the arteries, right, and basically cause them to constrict, okay, and increase that blood pressure. And so that's nervous system, right, going to the brainstem here. This is showing you the hormonal regulation, right? So again, remember the hypothalamus controls the pituitary gland, right? And controls hormones. And so ADH will again cause an increase in blood pressure here. This is the angiotensin, that renin-angiotensin system I mentioned on that last slide, okay? Also, if you talk about fight or flight, you're going to get increases of epinephrine and norepinephrine from the adrenal gland as well. That's going to cause an increase in blood pressure and a, constriction of the arteries. Okay, so you really should understand what's going on here. I mean, I kind of said you don't need to know every single detail in terms of like, angiotensin 1 being released from the liver and then angiotensin 2 from the lungs, like that sort of detail you don't need to know, but you should know that angiotensin 2 is going to lead to an increase in blood pressure. That release of norepinephrine from the brainstem is going to lead to an increase in blood pressure. That release of epinephrine and norepinephrine from the adrenal gland, right, is going to lead to an increase in blood pressure, okay? And also, again, you can see here, like aldosterone, right, is going to lead to changes in blood volume. If you're increasing blood volume, you're also increasing blood pressure, right? So there's both nervous system actions and hormonal actions that will change blood pressure. Okay, so some contributing factors: endothelial dysfunction. Remember we talked about the artery and the wall of the artery, that most innermost layer is endothelial cells. Again, sympathetic nervous system is going to affect it. And so if you're under a lot of stress, that's why we say stress contributes to high blood pressure, and you may have sort of chronic high blood pressure, right? Lifestyle factors, we talked about all this kind of already. Diet, right? High salt intake, lack of physical exercise, genetics, all of these things are going to contribute. I think on that last slide, on one of the slides before, we mentioned that race is a factor here. And so you do see higher prevalence of high blood pressure, right, in the non-Hispanic Black population. You can see that here. So this is in total, men and women, but you can see it even broken down in men and women, okay? And so there is a higher prevalence of high blood pressure in that population. So race does play a part in it, and that's something that you guys, should know as clinicians, right? That a non-Hispanic Black person would be more susceptible to high blood pressure. Okay, in terms of clinical manifestations, right? So some long-term consequences: stroke, heart failure, heart attack, right? Chronic kidney disease, vision loss, erectile dysfunction. All of these are things that over time can happen, right? So again, if you have high blood pressure over time chronically, it's going to lead to damage. You can have a sort of acute kind of hypertensive emergency, right? Where the blood pressure is so high that it's an emergency. Hypertensive urgency, and then also can lead to chest pain and dyspnea. Okay, obviously diagnose it, you measure the blood pressure, right? Easy to measure. In terms of treatments, right? So non-pharmacologic treatments, again, these are all speaking to those factors that we talked about before. If you drink too much alcohol, limit alcohol, stop smoking, lower the sodium in your diet, okay? Maintain an optimal weight, exercise, and reduce stress levels. A lot of times, if you really focus on doing these, you will see a significant decrease in blood pressure. Okay, if we talk about pharmacologic treatments, here are some examples of antihypertensive drugs and how they work. Okay, so again, if you see that, so just like we saw the positive before, which was an increase in blood pressure, or vasoconstriction, here a minus sign is going to cause vasodilation. And again, vasodilation meaning it's relaxing the arteries, relaxing the blood vessels, and obviously the pressure then would decrease. Okay, so you can have diuretics that will increase urine output and decrease fluid volume. Like I told you before, if you're increasing fluid volume or increasing blood volume, you increase blood pressure. If you decrease blood volume by essentially increasing urine output, we talked about things like this a couple chapters ago, it will decrease blood pressure. We saw on the last slide that angiotensin II will lead to constriction of the blood vessels. So if you block angiotensin II, it will lead to dilation, right? And obviously lower blood pressure, okay? Here again, ACE inhibitors will sort of block this pathway as well. So if you're never making angiotensin II, right, same thing, it will lead to dilation. Okay? Beta blockers will basically decrease here, right? Decrease the heart rate and the myocardial contractility, reducing cardiac output, therefore decreasing blood pressure. Okay, so you should be familiar with these. Okay, we should know that this angiotensin receptor blocker and these ACE inhibitors will affect this pathway, right? And then know the difference, kind of beta blockers and alpha blockers. These are all examples of pharmacologic treatments. Okay, so basically we mentioned all these on that last slide. Okay, so at least know a couple examples of these pharmacologic treatments. Okay, so you can kind of talk about first line antihypertensives and second line. Basically, they were all on this last slide. Anything that's not on this slide here, don't worry about. Okay, so best to just study this picture here. All right, and so that finishes chapter 23.